So before we begin, I would like to welcome everyone to participating in our meeting today. The purpose and objective for this meeting, you will remember at our last face-to-face statewide meeting, it was decided that because of time constraints that it would be better served by us pulling data together that we all have already either in our various agencies here at SHIP or various other agencies that were doing data collection, whether those be focus groups, surveys, or what have you. So what we've done is taken the time to collect all that data, and we're going to be presenting that data here today. And our prioritized populations team will help us comb through the data that we're going through today and help us decide what data should be going into our plan. But we wanted to make sure that everyone got a chance to see the data that's going to be potentially used. For each, there will be several presenters that will be presenting today, so we're going to ask that you please hold your questions until after each presentation. You have an option of typing in your question, and you can type it and we will see it. And then you also have the option of, at the conclusion of each presentation, verbally asking your question using the telephone. But again, we're asking that you write your questions down throughout the presentations and then save them for the end. We will only have a couple of minutes for questions, so if we do not get to your question, please don't panic. We will record all the questions, and then we will be able to answer them later in an email that can be sent to everyone. So I'm going to skip down to the next one that says place your phones on mute because we want to make sure that we are following our phone etiquette. So please try to ensure that your background is quiet, and if you can't control your background noise, at least put your phone on mute so that it does not disturb the call. Thank you. And going back up, this meeting is going to be recorded, and this is for your convenience. We understand that every planning group member is not going to be able to make it to the meeting today, and there's be a lot of data that's going to be presented, so you may need to go back through the presentation to kind of review information that might have missed you on the first go-round. And then lastly but not least, we will try to get in a break. We understand this is a lot of data to be presented in a short amount of time. So somewhere in the middle, we do anticipate taking a short break. All right, so we're going to get started with our first presenter. Well, first, this is our order of presenters. So these are all the individuals that are going to be presenting today. With the approximate amount of time that they will be spending. I won't go through this though.
Okay, so good morning. I am Jessica Fridge. I'm the surveillance manager for the Epidemiology and Evaluation program. So I think my section is the longest, but I will try and not actually take up 45 minutes. But this is really to give everybody an overview of HIV. There's a little bit of STDs in here. And then I guess I should say as well, as much of this as possible in time for the actual submission of the plan will be updated to accurate 2015 data. So a lot of places you'll see it says preliminary 2015. Some places it still says 2014. So again, in time for plan submission, we'll try and make it as 2015 as possible. So to start off with, we're just going to walk through some data basics just to get everybody comfortable with looking at data, make sure that when I talk about counts versus rates, everybody's got a good idea of what I mean, just so that the rest of the data goes more smoothly. So just some quick definitions of words that will probably be in the plan, but also words that get used throughout this PowerPoint. We do use the word incidence to refer to the number of new infections But when we're looking at HIV, we really can't count incidence. What we're counting are new diagnoses. So the number of newly diagnosed cases of a disease. We talk about prevalence when we're talking about the number of cases of a disease existing in a population. So for HIV, that's when we're talking about persons living with HIV infection. And then morbidity is just another term for illness. So areas of high morbidity. It means areas of high illness or a large number of diagnoses. And then mortality is, of course, another term for death. So when we're thinking about these words, this little sink picture is often very helpful just for remembering what we're talking about. So again, when we're talking about incidence, we're talking about new cases or new infections. But with HIV, that's really hard. So we kind of use the number of new diagnoses as a proxy for incidence. So that's the water entering the sink. It's the new diagnoses entering our surveillance system. And then for prevalence, we're talking about the water that sits in the sink. It's the water or the new diagnoses that get added to our current population of people living with HIV. And then people will leave that sink or leave our surveillance system if they move out of jurisdiction, so they move out of Louisiana, or if they pass away. So again, just remembering the difference between new diagnoses and then prevalence. So if we do some analyses on the New Orleans MSA, if somebody moves to Baton Rouge, that's like leaving the sink of the New Orleans MSA. So they're no longer part of the prevalence population of the New Orleans MSA. They're now in the Baton Rouge sink. So then just briefly the difference between counts and rates, because we see a lot how the media can take some numbers and really make them look different than what they mean. And so I think that gets most confusing when we start talking about how we rank. So we rank, second for HIV and second for AIDS, but those are rankings based on our rates. Those are not rankings based on our number of new diagnoses. So let's walk through that a little bit. So we can talk about a count, which is just a total or a tally. So that's just counting 1, 2, 3, 4, 5 new cases of gonorrhea. 1, 2, 3, 4, 5 new cases or new diagnoses of HIV. But if we want to see how those new cases compare across populations, we really need to use a rate or a proportion so that we understand how they kind of compare when we put them on even playing fields. So a rate is a proportion, and it's the number of cases, so that tally, the 1, 2, 3, 4, 5, divided by the total population that those cases came out of. So if we're doing a rate for Louisiana for HIV, we take all of the new diagnoses of HIV and divide it by the total population of Louisiana. If we want to do it for the New Orleans MSA, we take all the new cases in the New Orleans MSA and divide it by the entire population just in the New Orleans MSA. So you do have to compare, the top have to be apples to apples in terms of your population. So we can, just like we had incidence and prevalence for counting, we can also have incidence rates and prevalence rates and mortality rates. So all those numbers that we can count, we can also make rates out of them. So this is just an example I like to give in case people are not completely understanding the idea of rates. This one has nothing to do with HIV or syphilis. It's just, so let's say that I told you that there were 1,000 orange trees infected with a disease and only 100 apple trees in your orchard. You're a farmer, this is your giant orchard. 1,000 of your orange trees are sick, but only 100 of your apple trees are sick. So this is usually done in a smaller group setting, but I say, which group would you worry about? And people tend to chime in like, oh, I worry about my orange trees. There's 10 times more of them that are sick. So that's the conclusion you would come to if all you did was count 1, 2, 3, 4, 5, right? But now I tell you that in your field or your orchard, you have 100,000 orange trees, but you only have 110 apple trees. So that's your baseline population that you're working out of, right? So we need to do some math to get to a rate or to get to a proportion. And so for orange trees, I take my 1,000 diagnosed orange trees, and I divided it out of it my 100,000 total orange trees, and I find out only 1% of my orange trees are sick. So that's a little bit less alarming, maybe. But if I look at my apple trees, 100 of them are sick, and I only had 110 of them to start with. So 90.9 or 91% of all of my apple trees are sick. So I've put them on the same playing field. I'm looking out of their total population, and I find that in reality, my apple trees are way more impacted than my orange trees. And so that's what we're trying to do when we calculate rates for persons newly diagnosed with HIV. So this is an example that actually uses HIV data. This is from 2013, but don't worry about the fact that it's old. It's just meant to be an example. So if I just counted, again, 1, 2, 3, 4, 5, the number of new diagnoses or the new cases among blacks, the number of new cases among Hispanic Latinos, and the number of new cases among whites, these are my numbers. 904 new diagnoses among blacks, 60 new diagnoses among Hispanic Latinos, and then 315 among whites. So I might come to one specific conclusion here, just looking at my count. So we need to know our number of orange trees, or our number of apple trees, or our number of blacks living in Louisiana, our number of Hispanic Latinos living in Louisiana, and our number of whites living in Louisiana. And so I've populated them in the next box for you. And now we need to do our math to figure out what our rates are. So at the bottom, what's going to pop up is calculating the rate just for black. So I take the number of new diagnoses, the 904 cases, and I divide it by the total number of blacks that live in Louisiana, so apples to apples, and that's 1.4 million people. And I come up with this ugly decimal point at the bottom, 0.0006465. Nobody wants to have to say that out loud. So that's why we multiply it by 100,000 so that we end up with a rate that says 64.65. So let's do some rounding. 65 HIV diagnoses per 100,000 blacks. So that means for every 100,000 blacks that live in Louisiana, 65 of them were newly diagnosed with HIV. That's what a rate means, and that's how you get to it. So you'll often see with rates, it always says per 100,000, and that's because you multiplied that decimal point by 100,000. So I'm going to do it for all of my populations, and what I get is over in the far right. So my rate for blacks is still very, very high, just like the case count is. But if you now look at my rate for Hispanic Latinos, while we only, and I'm saying that in quotes, have 60 new diagnoses, the rate is much, much higher than it is among whites. So rates let us see, again, the impact that HIV is having across populations, but on a more even level than if we just sort of counted people without understanding the population that they're coming out of. Okay. Why is this not going? Okay. So for example, when we look at our New Orleans MSA rate, right, in 2014, the New Orleans MSA ranked 3rd in HIV case rate. That does not mean we had the 3rd most amount of new cases across the country. Clearly, places like New York City, Baltimore, Maryland, Miami, Florida, have way more cases if you count 1 to 3, but we have a much higher rate because our population is so small. Places like Atlanta, Georgia have giant, giant populations of 4 million that they're pulling from. The New Orleans MSA barely reaches 900,000 on a given year. So that bottom number is just so much smaller, so our rate is so much higher. So we rank 3rd for our rate, but we actually rank 19th for our case count. But that's not the ones that we share. We always share the fact that we're 3rd for our HIV case rate. So an example is Atlanta, Georgia had 1,454 new diagnoses. So 2.5 times more diagnoses than we did, but their ranking is all the way down at 7th because they have this giant population in Atlanta to be able to pull from. So The other thing I just wanted to clarify before we jump into the actual data, because I think people are always wondering, you know, it's Jessica, it's June, almost June 2016, you know, like how can the 2015 data not be done? And there's a lot that goes into making sure that the numbers that we share with you all, with our CDC partners, are truly accurate, because we certainly don't want to share numbers that then we have to keep retracting because we've cleaned them up better. So the way that we decide whether somebody is really a new diagnosis in Louisiana is a bit of a process. So there's going to be some boxes that appear on this screen. But I'm starting all the way over on the left. So for the most part, what happens is we get laboratory results. And we get laboratory results on every CD4 count and every viral load that is done in this state, as well as all confirmatory testing. So we have to go and do a good bit of work to figure out, did we get the CD4 count because this person is in a care visit for HIV, or did we get a CD4 count because they went and saw an oncologist or a dermatologist, which are all providers that also run CD4 counts. Because the labs don't know why that person had a CD4 count drawn. They know they have to send us every CD4 count and every viral load. So we get a lot of undetectable viral loads, but that doesn't tell us if that person is virally suppressed and has HIV, or potentially they are starting PrEP, and so that's part of their panel to be HIV tested and have a viral load done, and so they're negative. We don't know, so we have to go do the work. So all of the pending cases are sent out to field investigators who do full chart abstractions to determine if the person is positive or negative, or maybe more testing is needed. Maybe a provider doesn't understand the new HIV testing algorithm, and so we've got a positive screening test, a negative multi-spot, and no other testing. That could be somebody that's actually an acute infection, and we need to engage the provider or engage the DIS and get them to have even more testing done. So all the new cases come back to our office, and then we have to do a lot of follow-up to decide if, once we do all the follow-up to decide if people are actually positive or negative, we then have to do a whole lot of follow-up to see if they're really a new positive, or are they somebody that was first positive in Florida and now they're moving here. And if they're first positive in another state, they don't count as a new diagnosis for Louisiana. They go into our system, into that sync, as part of our population living with HIV, but they do not count as a new diagnosis of HIV for the state of Louisiana. So the other places that we get cases called in directly from out-of-state providers or providers here in our state. The GIS sometimes finds cases. So those are some other places, and those, again, we need to decide, are they really new or are they old? And then, of course, we get a lot of people that are diagnosed through the counseling and testing program and all of the rapid protocols that are going on. Those don't get the full chart abstraction because those people are being sent to us because they are positive. But again, we have to do a lot of work to decide if they're really new or not. And that work takes about 6 months. So when about 6 months into 2016 is when we start feeling good about what 2015 looks like. So again, just a little bit repeating about the timing. So people that are diagnosed in 2015, we might not even get some of them until February of 2016. If we've got a provider that forgot to report, or it's like a provider that's not used to reporting, we may get a really delayed report. And then for about the first 6 months, we're deduplicating cases with other states so that in the national CDC data set, we're not counting people twice. So it's really not until probably end of June, mid-July that we feel good about reporting out final numbers for 2015. And that's really, and then the last bullet point just says, in order to be accurate when we're talking about the number of people that are living with HIV, we also have to do a lot of matches with other states, but also death matches. And that, that matching depends on how fast Vital Records is moving. So if the Vital Records Agency hasn't entered all of the 2015 deaths, then of course our data can't be up to date. So So that just goes to explain, I think people want data as fast as you can possibly get it, but if we gave it to you that fast, it wouldn't be accurate, and you would be working off of numbers that that were really inflated, and we'd rather give you much more accurate data. Okay, so just a refresher in case anybody on the line is not familiar. Louisiana is comprised of 9 public health regions. Not every parish, which there are 64 of them, is part of a metropolitan area. So this next table on slide 16 gives you the names of all 9 regions, which parishes are included in each of those regions, and then which parishes are included in metropolitan statistical areas. And the metropolitan statistical areas that we tend to focus on are New Orleans and Baton Rouge. Those are the only ones that are large enough to be included in any of the CDC reports. The MSA has to have at least 500,000 people in order to be ranked in the CDC report. So that's why there's never a ranking for the Shreveport MSA, because the population is not large enough to get ranked on the CDC presentation. And then here's a map of all 9 regions. And then I think I'm diving in soon, I swear I am, but just as a reminder, when we follow somebody who's diagnosed with HIV in our state or moves to our state and has HIV, we really do follow them throughout their entire course of their disease. So people are newly diagnosed, we get a full chart abstraction on them then. We get all of the CD4 counts and viral loads that are ever conducted on them in our state. We follow them to a progression to AIDS. We do another chart abstraction at that point, and then we do complete their record all the way until their death. At the beginning, we also follow all children who are born to HIV-positive mothers. And so we have about 140 to 180 moms each year give birth, who have HIV, give birth to a child. We follow all of those children to see if they're positive or negative. Okay, so I don't think this will be news to anybody on the phone, but Louisiana in 2014 did rank second for its HIV diagnosis rate and second for its AIDS diagnosis rate. The New Orleans MSA ranked third for its HIV diagnosis rate and fourth for its AIDS diagnosis rate. You can see that the New Orleans MSA, both HIV and AIDS, are much higher than the overall Louisiana rate. And then for Baton Rouge, the Baton Rouge MSA ranked first for its HIV diagnosis rate and first for its AIDS diagnosis rate. And just as a reminder, in case anybody wasn't aware, the CDC changed the way that it defines an AIDS case for surveillance and calculating purposes. So it used to be that if somebody had a CD4 count below 200 or a CD4% below 14, one or the other or both, that they were considered to have, to be an AIDS case for surveillance. The CDC, starting in 2014, took away the part about the percentage. So now it's only based on whether or not you have an opportunistic infection or if you have a CD4 count below 200. The CD4% below 14 doesn't factor in anymore. So overall, all of our AIDS counts and rates look way better in 2014 and 2015. And some of that is real. Some of that is that the number of people that progress to an AIDS diagnosis is decreasing. But a lot of that has to do with the fact that the actual definition changed. So if you're trying to compare AIDS across time, I'll show you a map, but there's a good dip, and I'll point that out. So there's a great website, if anybody hasn't used it before, called AIDS View. They do a lot of mapping of HIV and AIDS data. You can look at it by race. You can look at it by parish. You can look at it by zip code for the MSAs. This is just the giant national map, which we showed to sort of clearly show the burden that HIV has on the South and where Louisiana has an important role. And then to hone in, so this one is about the rate of people that are living with HIV. So clearly the darker the brown, the higher the rate of people living with HIV. This purple one is about new diagnoses. So here, again, the darker the purple, the higher the rate of new diagnoses of HIV. And so you can see that Louisiana is the darkest purple. Remember, we ranked second. So if you look over Washington, D.C. as a state, which means it's confined to the actual borders, and if anybody's ever been to Washington, D.C., it's not big. So when Washington, D.C. is actually confined to its borders, it has a very high rate of 66.9, and then we are down there second at 36.6. But I'll show you on the next slide what happens when Washington, D.C. is considered to be a metropolitan statistical area. So on this slide, I put the top 20 MSAs and what their rate is. So you can see Baton Rouge is first, and then Miami, and then New Orleans, and Washington, D.C. is almost at the end. Washington, D.C. ranks 15th. Because now Washington, D.C. isn't confined to its borders. Washington, D.C. now, the metropolitan area of Washington, D.C. is parts of Maryland, it's parts of Virginia, it's parts of West Virginia. So it's this giant population that then makes their rate so much smaller. But Baton Rouge is first, New Orleans is third, and importantly, 16 out of the top 20 MSAs are located in the South. So all the blue ones are Southern, the yellow ones are not Southern. So again, this is preliminary 2015 data. In 2015, we had just about 1,200 new diagnoses. I would expect this to go down to about 1,150 in the next couple months. But the proportions really aren't going to change that much. So what we have is about 76% of our new diagnoses are among men. This proportion is increased. I always say when I started here about 8 years ago, it was closer to 60-40. So we've really gone from about 60% of our new cases among men all the way up to 3/4 of them. When we look by race, 71% of our new cases are Black and 21% are white, 6% are Hispanic Latino, and just under 1% are Asian, and under 2% are other or unknown or multi-race. And then this next box talks about people who reported a race. If you skip all the way to the bottom, you'll see that about 50% of our people don't have a reported race. So the rest of the numbers are only based on the people that did report a race. What? Oh, risk. Risk, race. They both start with R. Risk. So of the people who reported a risk, 68% of them reported being a man who has sex with men, and that is, for this slide, that is based on their birth sex. There is transgender data later, but this slide is based on birth sex. And that's why, or sex at birth, and that's why I said it up at the top. 7% reported injection drug use, 3% reported men who have sex with men and injection drug use, 21% reported being a high-risk heterosexual. This means that you engage in sex with a partner of the opposite birth sex, and there is something, quote, risky about that partner. So that partner has HIV. That partner is a bisexual male. That partner is an injection drug user. There has to be something high risk about that relationship. Under 1% of persons were perinatally infected, so we did have 2 cases of mother-to-child transmission of HIV. If we look by age, there's our 2 pediatric cases, and then 6% were diagnosed just between the ages of 13 to 19 years old. 19% were 20 to 24. So if you put those together, 1/4 of all of our new diagnoses are among youth, 13 to 24 years old. 33%, or 1/3 of all of our cases, are 25 to 34 years old. About 20%, or 1/5, are 35 to 44 years old, and then almost another 1/4 are 45 and older once they're diagnosed. And then when we look by region, 1/3 are from New Orleans, 22% are from Baton Rouge, And then another 11% are from Shreveport. And you can see Homa, 5%, Lafayette, 8%, Lake Charles, 4%, Alexandria, 5%, Monroe, 8%, and then Hammond-Slidell, 5%. So this is looking at HIV and AIDS over time. The yellow bars are the number of HIV diagnoses. The blue bars are the number of AIDS diagnoses. I put in a couple markers for you. So clearly, when Hurricane Katrina happened, that caused a disruption in our testing. If you disrupt testing, you can't diagnose. So if you diagnose fewer people, then of course it looks like our HIV numbers went down, but that may, again, just because we weren't diagnosing as much. So there's kind of a drop then. And then you see the drop among AIDS diagnoses way over for 2014 when the case definition changed. But overall, we are seeing improvement. People don't progress to AIDS as quickly. But that big drop from 708 to 603 is really because a lot of that is due to the definition of AIDS changed. So when we look at people living with HIV, at the end of 2015, right now we have about 20,585 people living with HIV that know that they have HIV, right? So when we divide that up by all these same demographic groups, 70% are male, 69% are black, and 26% are white, 4% are Hispanic Latino. By region, 35% of all of our people living with HIV live in New Orleans, 24% in Baton Rouge, 4% in Homa, 8% Lake Lafayette, 5% Lake Charles, 5% Alexandria. Shreveport has 9% of all of our people living with HIV, 5% in Monroe, and 6% in Hammond-Slidell. If we look at people living with HIV over time as well, again, you can see the impact that Hurricane Katrina had. We had a large number of people who moved out of our state. So we really didn't get back to pre-Katrina numbers until about 2008. And then since then, of course, we just keep on increasing as people are able to access medication, live longer. We have more people moving back to Louisiana, etc. And I know I'm rushing. I'm sorry. So here's a little bit of transgender data. This is 2014. It will be updated in the next couple months to 2015, and we'll get that out as soon as we can. But what you've got in kind of the grayish, bluish columns are the number of new diagnoses among transgender persons in 2014. And then in the light orange color is the number of transgender persons living with HIV in Louisiana. So in 2014, we had 11 new diagnoses among transgender women. We do try and capture gender identity from as many sources as possible, but of course this is not going to be completely accurate. So we capture it from medical records, we capture it from DIS interview, we capture it from case management files via Ryan White. If anybody's got ideas where we could capture it from, I'm all ears, but we do try and, as much as possible, capture gender identity when we have access. And then for persons living with HIV at the end of 2014, we have 162 transgender women and 1 transgender man living in Louisiana. When we look by race, of the 11 new diagnoses among transgender women, 100% of them were Black African American. When we look by persons living with HIV, 80% of our trans persons living with HIV are Black, 6% are white, 6% are Hispanic Latino, 13% are white, and 1% are other multi-race or unknown race. And then when we look at age, so this is a little bit deceiving. When we look at age for the blue, it's age at diagnosis. When we look at age for the orange, and the title is missing, it's current age, how old they currently are at the end of 2014. So when we look at age at HIV diagnosis, 5 of the 11 were just 20 to 24 years old. Another 5 of the 11 were 25 to 34 years old, and 1 person was between the age of 35 to 44. When we look at who's living with HIV, 11% are 20 to 24 years old, almost 50% are 25 to 64 years old. A quarter are 35 to 44 years old. That percentage is clearly wrong at the bottom, so I will fix that, and I can't read the one that's hiding under that bar. 13%, and then I will have to go back and figure out that. It's probably 4.5, and I deleted the decimal without deleting the 5, but I'll fix it. And then this just looks at reported risk again, and then by region. So of the 11 new diagnoses, 8 reported sex with men, 1 reported sex with men and being an injection drug user. For 2, we have no risk that was collected so far. And then for people living, for trans persons living with HIV, again, 83% reporting had sex with men. An additional 12% reported sex with men and injection drug use, and 8 people have no reported risk. And then by region, what's interesting here is if you look at where people were newly diagnosed, 3 of our trans women in 2014 were diagnosed in New Orleans, and 5 were diagnosed in Baton Rouge, 2 in Shreveport, 1 in Monroe. But if you look at where our trans persons living with HIV are living, over 50% are living in New Orleans. And then 23% are living in Baton Rouge, and just a handful are living in each of the other regions. So to skip to perinatal surveillance, and there's just one slide on this, each year, like I mentioned, we have about 140 to 180 mothers that give birth to infants in Louisiana. These are mothers that have HIV. Most mothers are diagnosed before they deliver, but some are, are diagnosed before they are pregnant, but some of them do get diagnosed during pregnancy, and then unfortunately, a very small amount over the past 5-6 years are actually diagnosed at delivery or after delivery. But you can see that each year, except for 2013, we still do have cases of mother-to-child transmission of HIV. And so we do full follow-up on those cases, but we also do full follow-up on all of the negative babies to make sure that they get all their appropriate testing. So my last few slides are about unmet need, and then I may have to stop. To look at unmet need, or the percent of people who are out of medical care, in 2015, right now, we have that about 5,679 people out of all of our people living with HIV did not have any HIV medical care. And so we say that because we didn't get a CD4 count or a viral load on that person for the whole year. And that's about 28% of all of our people who are living with HIV. People who have not yet progressed to an AIDS diagnosis are far more likely to be out of care than people who have had an AIDS diagnosis. Men are more likely to be out of care than women, and blacks and whites are actually equally out of care, but 46% of Hispanic Latinos were out of care and 39% of Asians. So when we look by age group, the proportion listed is the proportion that are out of care. So our 0 to 12-year-olds, about 16% of them are out of care. Some of this has to do with children moving or being adopted and moving out of the state. So if we lose track of them, then of course we can't be getting labs on them. A quarter of all 13 to 24-year-olds are out of care. 28% of 25 to 44-year-olds are out of care. 27% of 45 to 64-year-olds are out of care. And then 34% of people 65 and older are out of care in 2015. By region, you can see it's not, there are places that sort of are at each end of the spectrum, but New Orleans, 27% of people are out of care. Baton Rouge has the lowest unmet need at 22%, Homa 24%, Lafayette 31%. Pretty. Groovy. I don't know what that is. Sometimes when you put yourself on hold, it plays your whole music.
Oh, I can mute them. Go on. Just 1 second, folks.
Everybody dance. Dance break.
Audio.
Dance break. Dance break. Nice. All right. Okay, let's speed through this. By region, okay, I was on Lake Charles. Lake Charles has the highest percentage of unmet need at 36%, Alexandria 30, Shreveport 34, Monroe 32, and Hammond-Slidell 26% of people who are living with HIV are out of medical care in 2015. Okay, so a little bit about STD. I'm going to skip that guy. Just as a reminder, we have a ton of work to do with HIV. We also have a ton of work to do around STDs, and the more we can do that together, the better. So in 2014, Louisiana ranked 3rd for its chlamydia rate. It ranked 1st for its gonorrhea rate. It ranked 2nd for its primary and secondary syphilis rate, and we ranked 1st for our congenital syphilis rate, so syphilis among babies. We just closed our 2015 data, and things are looking a little scary. But for gonorrhea, we closed just over 10,000 new diagnoses, which was a 15% increase for our state. Chlamydia, we closed over 32,000 diagnoses, which was a 12% increase for our state. Primary and secondary syphilis, we closed at almost 700 diagnoses, which is a 21% increase for our state. And for congenital syphilis, we closed at 53 cases, which again was an increase from just 46 the year prior. I like to insert here that there are only about half the states in the United States even report 1 case of congenital syphilis, and we reported 53. So we have a ton of work to do. This would be similar to saying, you know, we're so used to small numbers of mother-to-child transmission of HIV, but this is mother-to-child transmission of syphilis. And then just looking really fast at co-infection, as a reminder, last year in 2014, we had 575 new primary and secondary syphilis cases. 39% of them were co-infected with HIV. And that varies by region. Some regions were as low as 20% co-infection. New Orleans I put on here because it has the highest one. Region 1, 58% of all of the primary and secondary syphilis was co-infected with HIV. And then there's one hepatitis C slide on here from a match that Antoine did. So he did a match between our HIV surveillance registry and the hepatitis C registry. In 2014, there were about 1,000 people living with HIV and hepatitis C. That's about 5.6% of all of the people who were living with HIV. And this is an underestimate because hepatitis C reporting is not quite as active as HIV reporting. So it's a little bit more of a passive surveillance system, so we know the percentage is actually probably higher. And it requires that people have been diagnosed with hepatitis C. If you break that down a little bit, when we look at injection drug users living with HIV, 21% are co-infected with hep C. When we look at a specific age group of 46 to 65-year-olds, we see that 10% are co-infected with HIV. Persons, the Lafayette region has the highest percentage. So persons living with HIV in Lafayette, 7% are co-infected with hepatitis C. And then when Antoine looked at trans women looking with HIV, 7% were co-infected with hepatitis C. So that's a little bit higher, again, than the 5.6% overall. If you ever need more data, these are all of our websites, and of course I'm here. Done.
You have a couple of questions that came about while you were speaking. The first question is from, that would be Jack Millaway. Jack asked if the 2015 numbers will be finalized before the integrated plan is needed to be submitted by nearly 2 months. Are we planning on updating the numbers to 2015 in the finalized plan?
I mean, I think that, yes.
Yes.
Yeah. They, as much as we can, if some things can't be done, but yeah, the goal would be that it's 2015 numbers to stand for a 2017 plan.
All right. Another question came in from Michael Freeman is, will this presentation be shared with everyone?
And I can answer that question. This presentation is not only being audio recorded, but the data slide sets will be made available for everyone. We will send out an email to show you, to say exactly what those are. We won't send it out in an email because that probably takes up too much room. So we'll have a designated place for you to go and find this slide.
And this is a question from Jada Cardona.
Yes, Jada.
Asking that how you explain the transgender data. And now you said that still that they're not complete because we're getting other sources, not directly from the people. So the numbers that you explained for hepatitis and everything are on the low end, we can say, because of those have not been reported. The numbers for the transgender are probably way higher for each category because they weren't really identified correctly.
So overall, you know, if we've only captured somebody by their birth sex, then they're being excluded from any analysis specific to transgender persons. So, yeah, so that's why if anybody has any ideas on how we can improve that collection, we are all ears, always.
Okay, thank you very much. Unfortunately, at this point, we're going to have to stop taking questions at this point in time. However, if you have additional questions after the presentation today, we will have a slide set at the conclusion of this presentation for where you can send those questions, and we'll make sure they're funneled to the correct person and that they're all answered and everyone sees the answers. Also, right before our next presenter, please know that we are going to answer questions after each presentation. Please also remember to not place your phones on hold. Place them on mute because when you place it on hold, we hear music and it interrupts the presentation. Thank you.
Okay, good morning, everyone. I am Debbie Wendell, and I'm also with the STD HIV program, and I'm the Data Management and Analysis Unit Manager. So I'm the person that works with all of the data from prevention, services, surveillance, and do some evaluation projects. So this morning I am going to be talking about the care continuum, and then I'll also have a couple slides that look at our linkage to care rates over time. I think probably most of the people in this room and on the call have seen our HIV continuum of care. But just as a refresher, I'm going to go over, for this overall continuum graph, I'm going to go over each bar, and then I'm going to show you some continuums for different subgroups. And I just wanted to mention that these data are for 2014, but same as with the surveillance data that Jessica just went over, we are going to update these to 2015 continuums once the surveillance data are updated. So the 2015 continuums should be in the report, and hopefully all of our indicators will look even better, but we'll have to see. So starting with the far left-hand side, this is the number of people who are living with HIV at the beginning of 2014 and are still alive at the end of 2014. So this is a little bit different than the overall prevalence data because we want to exclude both new diagnoses and we also exclude people who died during that year. So this overall number, 18,000, is a little bit lower than numbers you'll see for overall surveillance data. So again, we have about 18,000 people living in Louisiana during that entire year. 71% were engaged in HIV care. So really this is kind of the flip side of unmet need. So 29% have unmet need, 71% were engaged in HIV care at least once. And what we mean by engaged in HIV care is that they had at least one CD4 or viral load done during that year. So again, this is not a measure of good care, adequate care, it's just were they in care at least once. The third bar is retained in HIV care. And this is the definition for this, and this is based on kind of the CDC and national recommendations for developing these continuums. The definition is, did someone have at least 2 care visits during the year at least 90 days apart? So if they had 2 care visits during the year at least 90 days apart, they were considered retained in HIV care. So statewide, we have 56% of people living with HIV retained in care. And then the final bar looks at viral suppression. So with someone's viral load, their most recent viral load in 2014, less than or equal to 200 copies per milliliter. So we have about half the people living with HIV who we consider to be virally suppressed. And one thing that we added here in Louisiana is that that middle arrow going across, because it's really important to look at people living with HIV in care who are virally suppressed. Ideally, 100% of people in care would be virally suppressed. That's a goal we would want to work towards. However, not all people in care are virally suppressed. So statewide, 70% of people living with HIV who are in care at least once were virally suppressed. And that's a number that we continue to monitor. And it's also it's a useful percentage to use when you're comparing groups. You know, one major limitation with the continuum data is that we don't always know who's in the denominator. So we don't always know if someone who we think is living in Louisiana has actually moved out of state, has died. You know, we work really hard in our surveillance programs to update address, update death statistics, but sometimes we're overestimating who's living here. And so it's a little bit hard to compare groups when you're looking at the bars. So we're going to look at a few different continuums for some demographic subgroups. So this first one looks at the continuums by race ethnicity. So on the far left side you have blacks, and then we have Hispanics in the middle and whites on the right. So if you look at some of the different indicators, you can see that, for example, looking at who's in care, at least once, is big differences. 72% of blacks, only 49% of Hispanics, and then 73% of whites were in care in 2014. And you can see some of the other indicators differ by race as well. And really looking at that middle square, the arrow going across, to see what percentage of persons living with HIV in care were virally suppressed. Again, you see some big differences between blacks. Where only 67% of people living in care were people living with HIV in care were virally suppressed, compared to 75% of Hispanics and 77% of whites. Looking at the continuums by gender, although women are more likely to be in care, so 75% of women are in care at least once, 58% are retained, compared to 70% of males and 55% retained. If you look at viral suppression for males versus females, there is a difference. So 68% of women living with HIV were virally suppressed compared to 71% of men. So women are more likely to be in care, but men in care are more likely to be virally suppressed. And then looking at age group, we'll just, again, for age group, let's just focus on that, on people in care. So we have 62% of 13 to 24-year-olds were virally suppressed. So that's the group who has the lowest viral suppression. And then you can see it increases by age, 68% of 25 to 44-year-olds, 72% of 45 to 64-year-olds, and 79% of persons 65 and older. So we're seeing an increase in viral suppression the older you get. Looking at by risk factors, 72, some of these arrows got kind of messed up. We'll fix those graphics. But among men who have sex with men, 72% were virally suppressed. MSM-IDUs are very similar, 73% virally suppressed. However, we have lower viral suppression among injection drug users and heterosexuals at 67%. And then looking at men who have sex with men by race, there's also a pretty significant disparity where we have 68% of African American MSM virally suppressed compared to 79% of white MSM. And one thing I wanted to mention before I move on, we have continuum data for lots of different regions and subgroups. So if anyone's interested in a region-specific continuum, they can just ask me and I can send you a whole PowerPoint slide set. So just looking quickly at viral suppression among regions, you can see that there's a low of 68% in New Orleans, Lake Charles, Shreveport. Highest viral suppression is in Homa, in the Homa region. I just have two more slides looking at linkage to care over time. So the 2015 National HIV/AIDS Strategy goal was 85%. So our goal was to get 85% of newly diagnosed people into care within 90 days. And so this is something that we've been monitoring for many years. So you can see that in 2007, we were only at 67%, and we've seen a steady increase over time. Where in 2015, our preliminary data show that 82% were linked within 90 days. That may change slightly as we finalize our surveillance numbers. We got really close to the objective but didn't quite make it, but we're at least trending in the right direction. However, when the new National HIV/AIDS Strategy recently came out for the 2020 objective, it's still 85%. However, it's linkage to care within 30 days. So that's a new objective, and that's what we're aiming at with a lot of our current strategies. So I didn't go back too far, but I looked at the last 4 years, and you can see that, again, we're making steady progress. However, we're pretty far away from that linkage within 30 days. So in 2015, we're at 69%. Again, our aim is 85%. So we're working on doing a lot of things to not only speed up linkage programs, but also speed up some of our data collection systems and some kind of system issues to try to improve that. I think that is my last slide. So I'll take a couple questions if we have time.
Yes. We do have a time for a couple of questions. We didn't get any through the chat feature, but if there is someone on the phone, you can unmute your phone and ask your question. Okay. Hearing none, again, please be reminded that you will have the opportunity to submit questions later on if you would like to. So we're going to move on to our next presenter.
Hello, my name is Antoine Brantley. I'm a data analyst here at the FTD HIV program, and I'm going to talk a little bit about a strategy that we implemented starting in September of 2013 called Louisiana Links. This was a unique strategy that worked on helping to re-engage persons living with HIV in HIV care. So, like I said, this was a linkage re-engagement to care program and also a patient navigation program that was implemented in September of 2013. It was a pilot program that was funded under the federal grant CAPIS, which stands for Care and Prevention in the U.S. And that grant was really trying to find places that were looking to address social factors that were barriers to HIV care and HIV prevention. This strategy was unique in that it utilized surveillance data, so all the data that helped to populate the tables that you've been hearing about, to identify persons living with HIV that we suspected were newly diagnosed but not linked to care, or persons that were previously diagnosed but were maybe in need of re-engagement to care services, and also people who were in care but were showing consistently high viral loads and maybe in need of treatment adherence services. On top of that, all three of those populations we suspected may be in need of other social support services. So those types of services and social factors were also addressed in this program. So once those persons were identified, we referred those individuals to what we called linkage to care coordinators. These were what you might hear called patient navigators, or there's a lot of different terms for them, but they were in-house, and those were the persons that helped to address any needs that our clients had. And this program was initially implemented in 3 regions with the highest HIV prevalence. That includes New Orleans, Baton Rouge, and Shreveport. But it was also expanded in May of this year to include 4 additional regions, which I'll go over. So I'm just going to talk a little bit about what the linkage to care coordinators actually did with the clients and how they actually located clients. So first and foremost, the linkage to care coordinators and everyone that touched the data in this program follows the strictest levels of confidentiality that we have. So that was obviously very important because we were dealing with such sensitive data. And then also it's important to note that before implementing this program, we coordinated with a community advisory board in New Orleans to really go over the concepts and framework of this program to really get the community's buy-in because we were dealing with such sensitive data and actually going out and using our surveillance data to contact individuals. So it was really important to understand what the community felt and what their concerns were, and to even modify our program to meet their needs and concerns. So then once the linkage to care coordinators were trained as far as confidentiality goes, they had access to identification and contact information data for the referred clients from our surveillance databases. In some cases, we used other databases and tools to locate, current addresses and current information for those clients. And then the linkage to care coordinators attempted to locate clients until all methods were exhausted. We found that for some clients, they could be found very quickly, and then for others, it took a long time. But even after, it taking a long time, that those clients were really in need of the services that we were providing. And then it's important to note, too, that any additional information that the linkage to care coordinators found, any updated addresses, helped us to understand if individuals were out of jurisdiction or not, and we could update our surveillance data to reflect that. And then that also helps with us getting more accurate numbers as far as our care continuum. And then also we made sure to record any refusals or requests for no future contact, so that we weren't bothering individuals when they requested not to be bothered. And then once the linkage to care coordinator enrolled an individual, they went through a lengthy in-person evaluation and interview so that the linkage to care coordinator could understand any of the needs that the client had, and also to understand, what was the client's, kind of hopes and dreams, and how the client or how the coordinator could help that client achieve those things and achieve or address any of the barriers that the client was facing that was keeping them out of care and keeping them from feeling empowered. And so the linkage care coordinators would then go to the first few clinic appointments with the enrolled client. In a lot of cases, they had to act as an advocate for that client and help them to navigate through what can sometimes be a complicated landscape as far as navigating different healthcare services or different clinics and providers, and finding even the most appropriate provider. And then the linkage care coordinator would also provide referrals to additional social support services and may even attend those appointments or attend those facilities to help them with getting the benefits that they need. And then the linkage care coordinator would follow up with the enrolled client for 3 months, a lot of times, or longer. And then eventually the goal is to discharge them to a Ryan White case manager. But in a lot of cases, we find that clients, really got the services that they needed addressed by the linkage care coordinators, and they sometimes contact the coordinator even after they've been discharged to Ryan White to get some additional help. So just some brief results from the program after implementing it for 2 years. We found that 563 clients were enrolled, and that accounted for more than half of the referrals that were contacted and eligible, 58%. So we actually found very high acceptance of our program, and not the kind of percentage that we were expecting to refuse our services. In spite of the fact that this is such a sensitive program, and we were out there contacting individuals, with just our surveillance data, or cold calling them. And as far as the demographics go, the vast majority of clients were African American, so 89% were Black, And we also saw that Black referrals were almost 3 times more likely to enroll than white referrals, which may reflect the unmet need again, that our Black persons living with HIV may have higher needs and were more receptive to our program versus our white persons living with HIV. And then 53% were males, 28% were 29 or younger. We also found that that younger group was actually the most likely to enroll as well. And that, again, if you remember from the care continuum, they were least likely to be virally suppressed. So that may be, again, reflective of them facing more barriers to HIV care engagement. And then 31% identified as MSM, and 67% were out of care for 9 months or longer. So most of the persons that we were working with had been out of care for an extended period of time. And after patients were enrolled, we saw that 87% of enrolled patients were linked to HIV medical care or showed virologic improvement. So a very high number of enrolled patients, we were able to get them back linked into HIV medical care and into a clinic that was more appropriate or most appropriate for their situation and what they wanted. And then we even saw that more than 1/3 of persons that actually refused to enroll had linked to care within 30 days of the last contact by a linkage to care coordinator. So that could reflect that even having a brief encounter with the linkage to care coordinator may spark some interest in getting back into care. And so at the intake, the linkage to care coordinator facilitates a intake survey to understand what kind of barriers that patient was facing. And so we've done a brief analysis of those surveys that we collected for the first 2 years. And we found that most clients, 60%, reported socioeconomic barriers. So a lot of our clients that are enrolling in the program are facing different socioeconomic barriers. Those included lack of insurance, no reliable transportation, unstable living situations, limited or no income, or childcare not being available or affordable when trying to attend appointments. Next, we found 30% reported issues regarding stigma. So that could be external stigma or internal stigma, as far as not wanting to stay in care because it reminds them that they have HIV, or how they may be treated if they disclose their HIV status by others, not having a support group, or even how they may be treated in the clinic if it's a clinic that doesn't just treat or focus on HIV care. And then the third biggest group were people reporting mental health issues. 1/4 reported having mental health issues that acted as a barrier to their sustained care. And in most cases, them not having access to mental health care either. And then just through talking with patients and with what the linkage to care coordinators observed, there were many anecdotes that talked about other barriers that clients were facing to care. And all of these anecdotes are collected in the case notes that we collect, and also for barriers that we want to highlight, our linkage care coordinators write comprehensive case reports to detail this information and to capture it. So some of these anecdotes include previous negative experiences at clinics. So, we've heard stories of just extremely long wait times, or clinics just not being in close enough proximity to where the client is, or where they could get to, or clinics treating patients improperly. A lot of times our linkage care coordinators have had to go in and act as an advocate for our patients and really make sure that our patients are getting the best care possible and not treated unfairly because of their socioeconomic status or mental health issues or substance abuse issues. We've also seen stories regarding internal and external stigma that's faced by our clients, a lack of support from partners or family, substance abuse or mental health issues, other physical health comorbidities that aren't being addressed. A lot of times our linkage care coordinators will get them linked to just general medical care in addition to HIV medical care. And then also no access to education or information regarding navigating the healthcare system. And it's important to be able to collect this information because a lot of times we're not able to get information from people who aren't in care. Our needs assessment and other types of surveys that we do are generally on persons that are in care already. So this strategy allowed us to get a snapshot of what is going on with the population that isn't actually in care. And just briefly, based on the results of our pilot program, we've expanded and gotten additional funding to expand the program to 4 additional regions, including Lafayette, Lake Charles, Alexandria, and Monroe. We also hired 2 additional linkage care coordinators in New Orleans to deal with the high caseload, and also to prioritize our MSM and men with no reported risk as a proxy for MSM, to really prioritize that population as they have the highest rates of HIV transmission. We also did a number of upgrades to the referral list system to help with quicker linkage to care and to expand our target population so that we can meet more people. And that's it for me, and it looks like there's a break.
We have a couple of questions.
Oh, sorry.
We have a question from Jeff, and the question says, please explain why we look at the difference between viral suppression overall compared to viral suppression for those who are in care. Question is regarding the CDC slide.
That's Debbie's. So when we look at viral suppression overall, and we saw it was 50%, that's 50% of everybody who we think lives in our state and has HIV. But there's a lot of variables in that, like people could have passed away. People could have moved to other states, and we don't know that yet. And so potentially it's not as bad at 50% as it really is, because just because we are counting all those people as living with HIV in our state, if we're not getting any care labs on them, nobody is calling us to tell us, like, hey, so-and-so moved to Texas or so-and-so moved to Florida. We have to do a lot of investigating to figure that out. If people aren't getting labs, we don't really know where they are. So they're out of care. Clearly they don't have a viral load. They're out of care or moved to another state. But we don't get labs from other states. So the reason Debbie has that horizontal bar added to it is because if we then look at the people who actually were in care, we can see how that's really, we know these people live here, we know they had a care appointment, and it's really to go and show that just having that one care appointment can lead to much better viral suppression results. So, potentially, it is practice for people to have 3 to 4 medical appointments in a year, but even just getting that one medical appointment, just engaging in a little bit of care leads to much, much better viral suppression results at the end of that graph. So it's sort of trying to get rid of the idea that we don't, just because we say all these people live with HIV here in Louisiana, we don't know the exact number. So it's trying to get rid of some of that variable and show if people engage in just a little bit of medical care, it really improves their overall viral suppression.
We have a comment from Anthony Basco, and it says that I would assume it's because those not in care cannot be virally spread. I know a previous presenter mentioned the total number of people living with HIV isn't necessarily accurate due to clients moving in and out.
Right.
Jurisdiction.
Yes.
But I would add that both things are important because you wouldn't necessarily expect that those problems with the data in terms of overall who's living in Louisiana would differ very much from population to population.
Right.
So
it's going to differ most for like Hispanic Latinos where we see the most in and out migration, but
or even perhaps it would, people with a little bit more resources might be more likely to be moving back and forth versus other people.
Right.
So I think it's important to look at both indicators from a prevention standpoint because the population who are not virally suppressed are the ones who are most likely able to transmit the virus to someone else.
Right.
But obviously, that's true whether they're in care or or not.
And I think that's what Debbie was trying to get at with the other ones is if you put people more on a playing field, then the even playing field of let's just look at the people that did get into care, then you really see the giant differences between those who got virally suppressed. But you've kind of made it a little bit more even because you at least know those people got some care.
Yeah, and also I think when you look at just those in care, it also helps you realize health outcome disparities in the healthcare system, because if you would assume if everyone's getting the same level of care, they would have similar outcomes.
Right.
But, you know, obviously that doesn't take into account all the socioeconomic stuff going on in the background.
Okay, thank you. I think we're out of time for questions on this, but again, please remember that you can submit your questions later on. We're going to take a 5-minute break. We know this is a lot of information to comb through, so this is an opportunity to get water, do some bathroom breaks, and things like that. We'll be back in about 5 minutes.
Muted.
I know a lot of people may not be back yet, but we want to be respectful in folks' time. So we're going to go ahead and get started with the next presentation, which is data from the Louisiana Wellness Center.
Hi, I am Diana Rojas, and I'm going to be presenting the data from the Wellness Center. This data is essentially divided in two. It's the Intake Wellbeing Assessment Questionnaire and the Mental Health Tool. So this data is from July 2013 all the way through April 2016. The Intake Wellbeing Assessment Questionnaire, we had 4,078 individual questionnaires, while there were only 2,647 individual respondents. Of those people with any demographic information, 86% identified as being gay, bisexual, or straight MSM. The data I'm going to present is for these gay, bisexual, or straight MSM individuals. And as you can see at the bottom, 29% responded being African American. Now, that does seem a little low, but this is self-reported, and a lot of people do not answer all of the questions. These are the demographic measures that are measured in the Intake Wellbeing Assessment. As you can see, 99% reported being male at birth, 98% reported identifying as male gender currently, 82% reported being gay, 67% are single, 39% have some college education, where younger people and African Americans tend to have completed lower levels of education. 50% are employed full-time, 45% earn less than $20,000 a year, where again, younger people and African Americans tend to have lower income. And 57% are renting a home. These are the testing and risky sexual behavior measures. Can we move the, I can't see. Sorry, we're having some screen difficulties. Okay, so here we see that 91% of the respondents have ever been tested for Hep B, Hep C, HIV, syphilis, gonorrhea, chlamydia, HPV, or herpes. And those that were tested tend to be a little older. No. Sorry about that. 63% that were tested have been positive for any of these diseases. And again, those who tested positive also tend to be older. 26% stated that they had been diagnosed with an STD in the last 12 months. And this diagnosis is associated with being African American. 41% said that they are receiving medical care for HIV, and this receipt of medical care for HIV is again associated with African American race. 3% have given or received money for sex or drugs in the last 12 months. 33% said they had sex with a person they can't contact within the last 12 months, and those who responded yes to this question tend to be older and non-African American. 27% said that they had sex with a partner with unknown HIV or AIDS status in the last 3 months. These are the condom use measures. 52% stated that they had used a condom the last time they had sex, and condom use was associated with being younger and African American. The same trend was seen in condom use with receptive anal sex and insertive anal sex. With vaginal sex, condom use is only associated with African American race. And we can see that 7% of people used a condom the last time they had oral sex, and this is also associated with African American race. 65% strongly agreed that they were confident in their ability to put on a condom, and those that were more confident tended to be younger. 42% strongly agreed that they were confident in their ability to put on a condom after having been drinking, and these were also younger people. These are the sexual partner measures. So 30% stated that they had sex with one male partner. 83% stated that they didn't have sex with any female partners. And 96% stated that they did not have sex with any transgender sex partners. These are the social support measures. 88% said that they had family to turn to when in need of help. 94% said that they had friends to turn to. And support from friends is associated with non-African American race. 37% said that they get social and emotional support when needed. This is about the Wellness Center participation. 65% said that participating in the wellness centers has improved their ability to protect themselves and their partner from getting an STD or HIV, and this improved ability is associated with African American race. 59% said that participating in the wellness centers has improved their overall health, and 59% said that participating in the wellness center events has made them feel more connected to the gay community. This is just the number of tests that we have been done by the wellness centers for this specific gay, bisexual, and straight MSM population. As we can see, 12% were positive for syphilis, 4% were positive for chlamydia or gonorrhea using a urine test, 13% were positive for chlamydia and gonorrhea using a rectal test, 18% were positive for chlamydia and gonorrhea using a pharyngeal test, and 2% were positive for HIV. So I only have 2 slides on the mental health tool, so it's a little complicated. We've got 1,335 questionnaires for the mental health and 1,326 for individual responses. Of these with demographic information, 79% identified as gay, bisexual, or straight MSM. And again, the data that I will report is for these gay, bisexual, and straight MSM. Of these, 28% reported being African American. So here we just have a comparison. On the left is the number of referrals that would be needed based on the section scores of the mental health tool. And then on the right are the actual referrals that were made based on these scores. For the referrals needed, we see that the most was about 30% in mental health. And from referrals made, 10% of mental health referrals were made, which is most of all of them. I would say that a lot of these were not answered. So we do have a lot of unknowns here. And that concludes my presentation.
Okay, I think we do have one question, and that question is, what is the methodology for these surveys? Were they distributed across the whole state or specific areas? And I can answer that question real quickly. These are survey results from the wellness centers that are throughout the state. Every client that comes to the wellness center does an intake assessment, and we are highly encouraged to take the mental health assessment and the substance abuse assessment. So that's where these results have come from. And that question was from Jacqueline White. Unfortunately, that's probably the only time that we have for our question on this slide, so we're going to move on to the next one. And I will be the next presenter, and I'll be presenting on data that we collected conducting community engagement sessions that began in 2014. And these community engagement sessions were with African American MSMs and some transgender individuals. And basically what I just said was repeated right here on this slide. We did start that in 2014, and it kind of carried over into 2015, and so you're going to see some of the results from that data now. The purpose of this data was to engage the community, MSMs and transgenders, for the purposes of, knowing attitudes and beliefs around HIV care services, the relationship with the health department, social media awareness and prevention and treatment. And the areas in which you can categorize the responses can be summed up in 4 different areas. Those areas are social marketing, linkage to care, health department relationship, and HIV education and engagement. So there's going to be a lot of information on some of these slides because it's like a lot of anecdotal responses. So even though I know you won't be able to read it all or even in some cases see it, please be aware that we are going to be sharing these slide sets with you. So it's the reason why they're so full of information is so that later on you can go back and actually really read it and have questions if you need to. So in your opinion, what has been the most effective campaign for gay men? Some of the responses were, at the time, the It Gets Better campaign was really at its height, so a lot of people referred to that as a really great way or a model for reaching individuals. They suggested using venues or apps that that gay men would normally use, such as Adam for Adam or Jack and what have you. A respondent said a better question is not what are the best campaigns, but where can we access the campaigns, which I thought was an interesting response. And then another comment was made about the greater than AIDS being a good example, and also testing makes us stronger as a good example for social marketing. If you had to create a campaign, what would it look like, and what would the messages be? So one person mentioned the AND campaign. So I was not familiar with this campaign, but it's kind of lets people know the duality of a person, that you're not just a gay person, but that you can be a mother, a teacher, or a friend or neighbor, and that sort of thing. And so I think that concept rings well with a lot of individuals. And I'm not going to read all of these. I'm just kind of pulling out some of the ones that are the biggest things that people were saying. Skipping down, funders often request that the organizations do outreach and activities with the clubs and colleges around the U.S. Clubs may be oversaturated, so I thought that was a good point. So there were several comments about going into other venues to try to identify gay men and not using some of the most traditional things, use untraditional ways of reaching them. Also within social marketing, we wanted to know how identity, sex, self-esteem, and social media fit all together. I think some of the comments at the bottom are some of the most interesting. The idea of identity through social media, Facebook, Adam for Adam, BGC, Live, etc. Create a social media page to put out messages. Utilize methods that have worked online with a profit organization. Use shock and awe as methods. So, we know that they want to see things that are interesting to them. They want to see videos. They want to see things that are surprising. We do have some recent research that says shock and awe may work to some degree, whereas in the past, we know within public health, shock tactics are questionable about whether they can be effective or not. But we know through social media advertisement that videos and shock and awe actually does work. They also say create videos, images needed to be related to the target population. They want to be see people that look like themselves with something that kept being said. Relationship with the health department. What can DIS or health departments do to gain your trust and assure you that they have a genuine interest in your health? And again, I think pulling out some of the most, the most glaring type of responses is, consumers want to feel like they can trust the DIS. So some comments that were made were, DIS being clearly stating what their purpose is and what they're trying to locate people for. Empower people to know more about realities of living with HIV. Give people real images of people living with HIV. Have images that are from perspective of what does a DIS look like, a friendly doctor looks like, a receptionist looks like, for example. Positive health care messages. What is care? People giving more information about some of the free healthcare services. So there's a number of different things that they recommended that DIS could potentially do to make our relationship with them better. Again, I'm going to ask that you go through these with a fine-tooth comb on your own time to kind of look at some of the other responses. Linkages to care. Where do Black gay men go to access health care information services, HIV testing? Some of the biggest responses, again, were nightclubs, because that's traditionally one of the places that we can only go to get that information. But they also mentioned community-based organizations, and of course, people mentioned doing a Google search. One comment that I thought was really interesting is Black gay men will pay to go to a clinic as opposed to going to a facility that might identify them as a gay person. So those are things that we just need to keep in mind. How is the internet accessed by 18 to 29-year-olds? They mentioned things like school, smartphones, for example, so they went into a more conversation about how we could access them through smartphones using those dating apps that I mentioned earlier, like Adam for Adam, BGC Live, and what have you. Word of mouth was said to be a big way of doing that, and that can also be done in the form of, of items such as T-shirts and all caps or even billboards. Urgent care or emergency rooms are places that people get data, so we need to keep that in mind. And then, of course, STD clinics that are like on college universities. Other ways that linkage to care for 18 to 29-year-olds. So some of this kind of went into some more in-depth conversation where there was some back and forth. And I thought one of the things that was really interesting here is a conversation about why a particular person in the group said that their friend was not in care. And the response was because they were embarrassed by their status. They feel they are going to die anyway, so why bother? So these are things that we really need to take into account when crafting our plan. What do you think needs to happen in this current healthcare system for Black gay men to start accessing care? So the things that they were saying were like, making the facility more friendly, change the approach, stop being afraid of what services are available. I'm sure that's a comment towards the individuals themselves. Make people feel more comfortable and do not continue to just focus on club outreach. And then I think one of the last comments here, I know it's difficult to read, but what's coming out of this is that they made a point to say that Black gay men identify as Black first and gay second. So I just think that's something that we should, pay attention to. And then also linkage to care. Just really, this slide is really talking about, we asked the question about religion and how it affects the Black gay community. And basically what comes out of this is several, anecdotal statements about, that religion for some can be an issue. A lot of gay men don't feel welcome in various churches. And it actually goes on to say that it could affect people getting into treatment and being medically adherent because, they need to feel that support. And the African American church is one place that the African American community usually goes to find support, but they don't feel like they can always get that. What needs to happen to ensure that gay men access services? The complete overhaul is some of the things that some respondents said. Everything from record keeping to confidentiality. Providing good referrals is something that they wanted, and best services for client-centered services. What do you feel Black men in your are, why do you feel they are not accessing services and staying into care? There was a lot of comments here about incentives, and I felt like the respondents really understood that having good health care is its own reward. So they had really kind of evolved from the idea of incentives are being the reason why we need to come in and get care. Although we do understand why incentives can be important for some, many of these respondents kind of took it to the next step and were like, people need to get into care for their own sake and not just for some type of incentive. The other things that were important to them as far as making sure that people are value suppressed and could stay that way, support from family and friends was huge. Acceptance removes all barriers. I would love community support. I would rely on myself, empowerment, strength from within, and then my own inner strength. But I can't stress enough that support from family or friends was very much stressed. HIV education and engagement, reflecting on all existing programs, campaigns, projects, and efforts that have attempted to address HIV in your community, in our community. In your opinion, what has to happen next? Build relationships with the community. Build relationships with local businesses. Like we always say, untraditional partners. So they recognize that as well. They don't want us to just always reach out to them in the same traditional ways that we always have. So they want us to build additional relationship with gatekeepers to ensure the right people and information is disseminated, managing those personal relationships. So yeah, that's generally the idea. And this slide, real quickly, the idea here was we were trying to get at if individuals felt like that there was a black gay community or a gay community that they could get support from, and less people felt like that there was a community and more like a series of different cliques. And that makes it hard to identify a community and be able to find support from it. So, and this slide kind of goes on with that same line of questioning. We asked the question, like if a person were to come in your community, how would they find the gay community? And they, again, let us know that they find it's difficult to identify that community. And another question would, does that affect people getting tested or getting into care? And yes, clearly it does. And then just a couple more slides here. So this is a question about support networks again. This was about women and how women oftentimes are very strong support networks for many gay men. But they did also say that that can sometimes have adverse effects because those same women, if they get upset with you, can use those things against you and attack you. So there was a double-edged sword there. And then finally, we asked questions about PrEP. Most respondents didn't know anything about PrEP, like get PrEP for something. What do you mean, get PrEP? So many people didn't know. There was some respondents that had heard of PEP, even if they hadn't know the actual name of it, but we did explain that, both PrEP and PEP to them. After explaining PrEP and PEP to folks, then they seem to have a jog of memory, like, oh yeah, I've heard of that. Even one respondent that's not reflected on this slide even said, oh yeah, that's what I call my Truvada pill. So there is some knowledge of it, but we might need to do better work about making sure they understand the correct ways to identify those, the new drugs. So that is the conclusion of this presentation. Are there any questions? Not at all. Awesome. Are there any questions on the phone? We only have time for one.
I have a question. What was your, did you have incentives or what was your recruitment strategy?
Yes. So we worked with various, so the question was, what was your recruitment strategy, methodology, and incentives? So we worked with our wellness centers throughout the state, and they helped us recruit individuals from the target populations. We did two sessions. We did a session of MSMs and a session with transgender individuals. Each recipient was given a gift card, a Visa gift card that was, did you want that dollar amount?
Yeah.
It was a $50 gift card. And the reason why we made it so hefty was because, again, we're talking about transgender individuals. They clearly let us know that their time was valuable, and they wanted us to value their time. And so trying to be respectful of that, that's why we did that. Okay, and so our next presentation will be the National HIV Behavioral Surveillance.
Hi, so I'm Kiva Fisher. I'm at LSU, but I've been with the National HIV Behavioral Surveillance for quite a while now, and I'll be talking to you a little bit about it here in New Orleans. So the National HIV Behavioral Surveillance, what we call NHBS, is a CDC-funded project that operates in over 20 different cities around the United States. So it uses behavioral information to monitor risk for HIV. And the purpose is really to inform HIV prevention services around the city based on what we have in terms of data. So we look at prevalence, so sexual risk, substance abuse, HIV testing behaviors, And we also look at access and utilization of prevention and service organizations in HIV prevalence. It's important here, we've been talking a lot about positivity, but we look at risk behavior. So we have both negative and positive people who come and take our survey. So the method is we do an annual survey in rotating cycles for 3 high-risk populations, men, sex, men, people who inject drugs, here written as IDU, and heterosexuals at high risk for HIV infection. We do a qualitative portion and a qualitative portion, the qualitative and a quantitative portion. Qualitative is formative research that we do in the beginning before we start our quantitative section in the end of the year, which is usually 3 to 5 months. So we use 2 different recruiting strategies. We use respondent-driven sampling for injection drug using cycle and high-risk heterosexuals. And then we use daytime sampling for men who have sex with men. Each site has a target sample of over 500. In New Orleans, we usually exceed that, which helps us in the long run have more participants to work with. And then we have HIV testing component for the IDU cycle. We also have hepatitis B. That's biomedical testing that we do in the form of either a rapid test or a confirmatory test. We're on our 12th cycle right now. That's high-risk heterosexuals in 2016. And we started in 2003 with men who have sex with men. We've published significantly throughout the United States with these data, with over 120 publications, and then there are also MMWRs and HIV surveillance reports. So this is our map. This is as of 2016. We added 2 sites recently, and these are all the participating cities throughout the United States. You'll see New Orleans at the bottom there. And they cluster in the northeast and also along the west. So the specific population findings, so this is where I'll present some of the data that we have already looked at that are available in state reports. First would be people who inject drugs, so IDU, then we'll go into heterosexuals living in high-risk areas, and then men who have sex with men. So the eligibility criteria for people who inject drugs is that they live in the New Orleans metropolitan statistical area, are over 18 years old, and are able to consent and take the survey in English. What's specific about this population is that you have to have injected drugs in the past 12 months, and our interviewers are trained to be able to identify those individuals. We use respondent-driven sampling to recruit these individuals in the form of a few individuals who we call Cs, who then are incentivized to recruit up to 5 of their peers. This has been kind of gold standard for this population. And other data collection efforts for HIV and hidden populations. And then we do this until our sample size is met. So this is what RDS looks like, respondent-driven sampling. It's a chain referral system, and you'll see these are individuals that are, and the networks that they bring in. You'll see here indicated there's a seed there. So that person recruited all the people that are linked to them, and then those individuals recruit other people until we get these pretty little graphs here. And basically, the reason why this is important is because once we reach a certain number, and our threshold is 500, we get what's called asymptotic representation of the population. And usually, people just say that this is kind of what a representative sample of people who inject drugs in New Orleans would look like in terms of our statistics. So race, ethnicity among the people who inject drugs in New Orleans, you'll see the breakdown is pretty similar to the breakdown of the New Orleans MSA. You have 56% Black African American, 38% white, and 5% other. Gender breakdown, we have predominantly male population, so 80% identified as male. And then for the age category, you'll see here that it's used to the older populations, which is something that the CDC and our specific site has been trying to address. It's a little bit harder to do that, but we were able to try to address it by having our individual feeds as younger people to try to tap into those younger networks. And we were able to see that kind of come down in this past data collection effort. 85% were identified as heterosexual or straight, 3% as homosexual, gay, or lesbian, and 12% as bisexual. So you'll see 100% for ever injected drugs, and I'll just remind you that a part of our inclusion criteria is that they had to have injected drugs in the past 12 months. So that's why that number, that percentage is complete at 100%. We see 56% sharing needles, and then also 86% used non-injection drugs. So this isn't necessarily to say that they are polydrug users, but that they just ingested in other ways than injecting. In terms of HIV positivity, so people who self-reported as positive and also got a confirmatory dry blood spot as positive was 8% of the sample, and then 3% were newly detected positive. That is to say, they came in to do our survey, and then they did a preliminary test and a confirmatory test, and they had no knowledge of a previous positive test. 13% had never tested previously. So for heterosexuals at increased risk for HIV infection, you'll see that our eligibility criteria is that they had to have lived in the New Orleans MSA, be over 18 years old, and able to consent and take a survey in English. What's important here is that they had individuals who participated were only eligible if they had sex with an opposite sex partner within the past 12 months. RDS, the same sampling strategy used among people who inject drugs, is used in this population as well. And these were, and the individuals that we identified at the beginning were identified through our maps that we made for high-risk areas through census tracts. And then we recruited among the highest, so recruitment was limited among high SES or education respondents. That's just to ensure that our primary exposure was shown. So here's our map. Just for clarification, this is not an HIV positivity map. It is a poverty map. So all the areas that you see in blue are areas of high poverty. So these are places that we sampled, and we would actually go into these communities and do systematic social observations, identify people to communicate with, and do community key informant interviews. And also the way that we identified who the seek participants were based on an extensive formative research process. So the data, the demographics for heterosexuals that increased risk for HIV were so 91% of them were Black or African Americans, 53% were male, and the age categories are pretty standard. 90% identified as heterosexual or straight, 10% identified as homosexual, gay, or lesbian. And I want to remind you that this is not about sexual identification, it's about behavior. So the inclusion criteria only speaks to whether or not they had sex with a partner of the opposite sex in the past 12 months. 20% had ever injected drugs, and then 51% had used non-injection drugs in the past 12 months. 5% were self-reported positive, or they had previously known or had a HIV positive test. 2% were newly detected, so those are the 10 individuals, and 16% had never tested previously, which is the highest among the 3 high-risk populations. So MSM, men who have sex with men, the eligibility criteria is that they lived in the New Orleans MSA, again, over 18 years old, and able to consent and take the survey in English. What's different here is that you had to have sex with another man in the past 12 months, be born male, and identify as male. You use VDTS, or venue-based daytime sampling, for
this population, and that is a systematic way. The way we do that is we go to certain venues in the New Orleans area that identify as 50% or more MSM, and then we enumerate and systematically approach people that way. So the demographic breakdown, we see that it's predominantly white, over 50% were white, and 100% were male because of the eligibility criteria. They were born male and identified as male. This is going to change. The reason why this isn't the transgender population is not included here is because the CDC has identified that as a population they'd like to also collect data on, and some of the questions are not sensitive to this population, so they're trying to address that with a separate cycle. And then you'll see the age breakdown. We have a lot of young people, and then also towards a little bit older. So 80% identified as homosexual, 17% as bisexual, and 3% identified as straight. 10% had ever injected drugs, and 50% used non-injection drugs. So for HIV positivity, 22%, 150 people in our sample had previous HIV positive tests that they knew and indicated to us. 22 people, or 3%, were newly detected as positive, and then 4% had never tested previously. That's the lowest among all the populations, and so it indicates that we're doing pretty well in this population. So we also have the opportunity at every city to look at locally specific topics of interest. In MSM, these are, we looked at smoking rates, PrEP awareness, hotspot communities, and stigma. Then for people who inject drugs, we've been really focused on overdose experiences, needle access, hepatitis C, and looking at more recently population estimations. And then for heterosexuals at increased risk for HIV, we look at geography, social determinants, and condom brand awareness. And then future funding that we are looking into is, of course, this NHBS transgender cycle, which we hope to start in 2017. And then young MSM, which would be people or MSM who are between the ages of 14 and 18. And that will start hopefully in 2017 as well. We have done hepatitis B testing for people who inject drugs in our previous cycle, previous 2 cycles, and we hope to continue doing that. And then we'd also like to do some STD testing if possible. And then this is Dr. Robinson, who is here at Austin Public Health, and also LSU.
No questions from the audience.
Okay, great. And if you would please be kind enough to hold your questions, and we'll get to them later on. At this point, I just wanted to make a quick announcement that we are at the 12 o'clock hour, which we are scheduled to end at this time. So we totally understand if some people need to leave the call at this time. But for those of you who are able to stay and hear the remaining presentations, do so. We only have about 3 or 4 presentations left, and I think they're relatively short. So if you would please bear with us, I think we'll be through within the 30 minutes. Our next presenter will be Allison Bertebeck, presenting on syringe ethics, and I will control the slides for you, Allison. Allison, are you there? Oh, we put all the calls on mute. I'm sorry. Are you there?
Yeah, I'm here.
Okay, fantastic.
Great. So I'm just going to really briefly talk about NOSAP, the New Orleans Syringe Access Program. So it's a fixed site exchange program that we operate out of the CAN office, a satellite prevention office of Crescent Care, doing business as No AIDS Task Force. It is referred to Access. It can also be referred to as NOSAP. We operate just Fridays from 2:30 to 4:30 p.m. Next slide. So we give access to sterile syringes and other safer injection equipment. That includes cottons, cookers, sterile water, tourniquets, and other things that prevent poor health outcomes for people who inject drugs. The program runs on a sort of one-for-one exchange where people bring in used syringes and can replace those with sterile syringes. If someone comes in with 0 up to 10 syringes, we can give them a pack of 10 syringes. Next slide. So in 2014, so NOAIDS kind of adopted the program from Drop-In Center sometime in 2013. I was not working at the agency at that time. In the calendar year 2014, a total of 570 unique individuals, and we know that we have unique individuals because everyone fills out a brief intake form with a client ID, a non-identifying client ID that involves the first name and year of birth. We saw 570 unique individuals in 2014, just under 300,000 syringes disposed and distributed, about 82 clients a week. In 2015, over the whole year, we saw 727 clients, so a pretty large increase. Oh, please go back. That was last slide. And jumped, so in 2014, under 300,000 needles. 2015, we distributed 528,000 syringes. Still seeing about the same number of clients every week, but a much larger variety of clients. And then next slide, so far in 2016, we have seen, this is at the end of April, so we've actually surpassed our numbers from last year just in the first 4.5 months. We see an average of 105 folks coming through our doors in those 2 hours a week. We've already distributed about 250,000 syringes and disposed of just less than that. This program is supported through a few small foundation grants and then donations, since we cannot use federal or state funds to buy syringes. The agency finds other ways to support that. We spend about $25,000 a quarter on equipment, and then previously we used a vendor to properly dispose of medical waste, and that was running us about $3,800 a month. We have a new vendor, but still this is over $140,000 annual operating costs just for equipment and disposal of used syringes. So this does not cover overhead, personnel time, any of those other costs associated with facilitating the program. And we're seeing an incredible amount of folks who are at risk for HIV, hepatitis C, or are infected with those. We help them access care, and no one is funding us to do this. No one's getting credit for all this work. So if any of you know anyone who's looking to write a grant, looking to provide grant funding, we will be happy to give credit for your state or federal dollars to be spent on serving these clients. Next slide. So we also offer rapid HIV and hepatitis C testing every Friday. There's a few times when we can't just due to staffing. We give information on safer injection practices. We have referrals for substance abuse, and we've actually partnered with CADA to have a representative around. So if people want to initiate the process of getting into services for detox or other services, that can happen. We give out loads of condoms and then provide referrals and linkage to medical care. One of the greatest successes has been having a navigator to help people who are identified as hepatitis C positive get into medical care and get on treatment for hepatitis C. And we've had anecdotal stories of clients coming in saying, thank you, you all have cured me of hepatitis C and I don't have that anymore. So it's rewarding work, it's hard work, it's very busy for 2 hours. But we're reaching lots of folks. Next slide. I'm not going to cover this since it's going to be shared, but we do have a high percentage of folks who are self-identified as hepatitis C positive, and then when we look at our hepatitis C numbers, the folks we're testing, the positivity rate is about 50%, if not higher. Next slide. You can skip this slide. I've already kind of discussed it. So we have 11 core volunteers who've been donating their time. That is a big way we are able to operate this program. And one of the volunteers, who's also a PhD student at Tulane, wrote a small grant to get $1,000 to distribute biohazard containers to clients. So they have a variety of sizes of containers so that people can take the containers with them, fill them up, and bring them back. This provides a safe space for syringes to be stored. Very obviously, something someone doesn't want to put their hand in, and people have really appreciated it. Not every client wants to take one, but we do what we can with the resources available. Next slide. So this is my information. I want to give credit to Lucas LaCava, who put together this slide. He is a prevention specialist at the task force in the CAN office. He will be here for one more week. He's vacating his position to go to med school, but he has been integral in helping us sustain our efforts with NOSAP. Michael Freeman, I see you asked a question about local law enforcement. So we don't have, I would say, a strong relationship. It is very well known that this program happens, and it is, it seems sort of like law enforcement turns a blind eye. Folks aren't getting arrested as a result of coming through our program. We are fortunate that that is the case. We are working with EMTs and the City Health Department to be able to distribute Narcan, which is the overdose antidote. Naloxone is the actual drug name, Narcan is the brand name. And so I think as we continue to forge new relationships with city health officials regarding people who inject drugs, that our relationship with law enforcement will change. We've had one incident where state police arrested someone outside of our building, but it seemed like that was very isolated and specific, and they knew that that person, they were looking for that specific person because no one else was bothered, and I think it was unrelated.
Fantastic. Okay, I don't think we have any time for any more questions, but I want to thank Kiva and Allison both for sharing this information, because otherwise we wouldn't have as much IDU information, so we are extremely appreciative of that. Thank you. All right, our next presentation would be the stigma index. We have requested from LPHI information around the stigma index. That information is not available as of yet because they're still collecting data, but they have agreed to share that data with us once it is collected, which I believe will be a little in a few months from now. I think by August, so we should be able to look at it by that time. All right, and our next section is our listening section by the New Orleans Regional Planning AIDS Council.
Hello, my name is Erica. I'm representing the New Orleans Regional AIDS Planning Council today in our activity that we are calling the listening session. So just a short version of our mission. As a planning council, Rhine White Party Planning Council, we are basically charged with ensuring the NSA, or the New Orleans metropolitan statistical area, is doing what it needs to promote positive health outcomes for all. So our planning council determines what services are needed in the community, how much money is needed for each of those services, and what service models are needed to help achieve this mission. We aim to ensure that the Rhine White Party dollars are working for the community. So when it comes to knowing what is needed, our Community Coalition Committee is really responsible for collecting data and community input to inform our annual and long-term planning processes. In January, they committed to looking at 5 special populations to examine ways to address their special needs. Those populations were selected based on EPI data. You saw a lot of that this morning. and or general knowledge of persistent barriers and health disparities experienced by each of those. Those 5 groups were young MSM of color, transgender men and women, Black women, undocumented Latinos, and adolescents. And so really our purpose in doing these listening sessions which were really kind of formatted like focus groups, was to capture current information and themes regarding issues that affect groups of people living with HIV, to identify ways to strengthen the local system of prevention and care related to HIV. And we had 3 key questions. So what does the EPI data show about key points in the care continuum where this population struggles? What special needs and gaps exist? Do they experience, and what hinders their optimal health outcomes and progression across the care continuum to viral suppression? What capacity or resources exist to meet the special needs of the population? So really this was an opportunity for a check-in with the key groups. How is the Metropolitan Statistical Area, MSA, doing for each of these populations? Because, you know, when you ask, people will tell you what is not okay. Okay, so here's the EPI data is really our springboard. I was able to insert some slides on the continuum of care, so you get to revisit this. You can take, you know, in these notes later. So here is a continuum of care for the New Orleans MSA for 2013, comparing young African American MSM 2029, African American MSM overall, and white MSM. You'll see the red arrow is showing the 63% viral suppression among young African American men. And you can see that compared to white MSM overall, they're at 83%. So we know that, you know, they're among young men of color, the HIV rates, infection rates are still high. We know that treatment as prevention is a prevention tool. So if we decrease viral load in the community, we can also decrease transmission. And so if you increase viral load, you're increasing the likelihood of infection. So we're hoping that, you know, all the populations can reach, you know, a viral suppression. So Debbie introduced the continuum of care earlier and the usefulness of the percent viral suppression among people in care for comparison across groups. I highlighted the differences here. You'll see that there's 20% difference between that young African American group and the white MSM in terms of viral suppression. It's a great illustration and provides kind of focus, are we meeting the mark? So one thing I'd like to think of it is like, if we can't achieve health equity among the groups that are in care with all the wraparound services that we have for them, how are we going to be able to achieve that for the overall population? Of course, we know PrEP is a new tool, so we can even prevent infections in the first place so that we're not adding to the community viral load. So here we have Black women. And this was actually for 2014. I just used the slides that I had at my fingertips, and you'll see the red line. So women, so that's the 78% is their being in care. So women tend to be in care, even better than the other populations. They tend to be retained in care. And then we see, you know, this issue of their viral suppression. 61% viral suppression of those in care compared to 75 and 70%. So it makes you think, what's going on? So another thing that we notice when we look at our late diagnosis data is that Black women also tend to be diagnosed late. Okay, so now the Latinx group. The reason why it's now just Latinx or Hispanic, Latino, and not undocumented is because we don't really have continuum of care for undocumented specifically. So here we've got, you can see that their being in care or linked to care is at 63%, which is less than the other groups. But you see, interestingly, their viral suppression for those in care is pretty good. Next one. So adolescents was another group for us, and so among those, we've seen improvements over the last several years. So 13 to 24 for that age group, we've seen better linkage, engagement, and viral suppression. So right now they're at 63% for 2014, compared to, you can see that they're lower than the other groups. Okay, so moving on to what we did. So we wanted to find out more about these key points within the care continuum, what was going on. So our methods for recruitment, we had planned methods and recruitment. We planned to have independent client and provider sessions for comfort of participants. For client sessions, we tried to leverage our relationships, much like the wellness center focus group that Michael had presented, so that we could actually get folks to the table. For the provider side of things, we recruited provider participants who are known to be particularly knowledgeable, sensitive, and are passionate about serving the special population. And what we did was we used kind of a focus group format of having a guide organized around the continuum of care, different stages in the continuum of care. So testing, linkage, retention, and viral suppression. We had incentives including food and gift cards. We didn't really advertise like, hey, $50. It was more like, we have incentives. Better incentives probably would have helped. So what I'll show you here is that, so we had our 5 groups. We did best, logistically this is all very challenging, but we had a young MSM of color group, and you can see we recruited through peers, and we got 3 people. Black women, we held that one. It was embedded in an agency's kind of ongoing event, 6 people. Then we had to table the Latinx group. There was a rainy day in there. We used a case manager. We also went through a peer for their support group. But anyway, things didn't work out. And then after all the logistical challenges there, we tabled the trans men and women one. And then we figured the Adolescent Trials Network at Tulane has done quite a bit with adolescents, that we would try to get information for our integrated plan from them. So on the provider side, you can see that we held those 4 sessions we had, and you can see how many people attended each. So we had a smattering of people, linkage people, program administrators, clinicians, etc. participated in that. Okay, so the overall summary, like Michael said, it's hard to summarize these kind of discussions. So I'm glad you went in depth with the young men of color. Wait, was it young men of color? Okay, and transgender folks. Because I'm going to ask you guys to refer to our slides later. I'll just give some highlights. So overall, in summary, these things, some of these things are not, earth shattering or shaking or whatever it is. Stigma and fear, the challenges with relationships with providers. There's so much stigma and fear. People have to have relationships to be able to overcome and take care of those challenges to take care of themselves. Same with basic needs. Basic needs are a huge barrier. People are dealing with housing, employment, transportation, food access, things like that. There were some things that came out super loud and clear with these different groups. Young MSM of color, housing, employment, and someone to talk to. These are the housing employment issues being outstanding barriers along the continuum of care, and then that needing a point person to talk to. Now we saw, like in the wellness center data, they showed an association of not having social support with African American race. We know most of the folks at the wellness center were men. So, it seems that a lot of the presentations kind of supported all this stuff, so it's nice to see that. For Black women, loud and clear, comfort, connection, and strong relationships with providers. They want to feel that there's sincerity in the delivery of services, and that that person truly has their back. There's lots of documented about challenges or trust in the healthcare system. So, again, strong relationships are so important. For Latinx, they said, we looked at the continuum of care. Once people are in, they do pretty well, viral suppression, but solid bilingual testing and linkage, rolling out the red carpet to make sure people get in care is important. For transgender men and women, of course, the number one thing, the largest thing, was sensitivity of providers to transgender needs. So later here you see that there's a detailed notes by population and you can pour over them. Some things were so local to New Orleans that I didn't put them in there, but this didn't help with our integrated plan. So last thing. So overall, this effort to focus on the data, look at challenges in the continuum of care, and then to go ask specifically to the populations affected was an opportunity to check in specifically on the severely affected special population versus a needs assessment survey, which often captures a lot of information for the whole general population, and some of these issues, underlying issues, don't come out. So we'll be using it in our summer services planning and allocations. It's also going to help to inform development of directives or strategies to adjust priority populations and other systems issues, and we obtain details about how the local system is and isn't meeting the needs of the special population. Behavioral health care, access issues, case management issues, social support services, quality of care, and outreach. So please feel free to look over, or if there's questions, you can reach us here, and then we have I just want to show how it's laid out. So among all the populations, we have so any prevention needs. A lot of them you'll see was just like what Michael found in his focus group. There's also testing, linkage, retention, and viral suppression. So all of these go through the whole continuum of care to pull out important points. Thank you.
Thank you. Thank you. So just trying to keep in line with our time. So let's try to go on to the next presentation. That would be from Jack Carroll, a series of town hall meetings that he's conducted. Jack, are you with us?
Who is it?
Jack
Carol has left the call.
Yes. Okay. So we will have those data sets available for you, but the presenter is not available at this point. But there was a series of focus groups that were done in these areas, and these are the dates on which they were conducted. And I'll just kind of slowly go through these slides a little bit, just so you can read them real quick. But most of them are, you know, very similar to what Erica and I did as far as kind of focus group, but they were town halls, so people were allowed to kind of, you know, share their opinions. And so there's a series of barriers that they have listed here. And so at your leisure, go through these and see what the barriers are for different areas. I'm sure there are some commonalities between some of them, and maybe some things that stand out for specific areas. Okay, and then last but not least is our presentation from the Philadelphia Center, which are also some surveys that were done there. That will be presented by Michael Freeman. Michael Freeman, are you with us?
Yes, he's on mute.
Give me just a second, Michael. I need to.
Can you hear me now?
Yes, we got you.
Okay. This is surveys that we took from the men's group. It was 19 respondents. This is all clients that are in care and men of sex with men. As you can see, 37.5% showed in the ages of 13 to 24 and 35 to 50. Next slide. When it's asked about their job situation, 20% all showed with that they really want to work but they can't find a job. They're scared they'll lose their benefits, and that they do odd jobs, you know, for cash, kind of under the table, and that 40% is working part-time. Next slide. Kind of living situations and where you're staying. 25% is some type of shelter. 25% is temporary housing, and that's, you know, just a month to 3 months. And then 50% said other, which would have been staying with family, friends, or, you know, staying with someone. Next slide. When you have sex you prefer having sex with, 20% said mostly women, sometimes men, and of course 80% said men only. Next slide. Since you tested positive, talking about condom use or some type of barrier during sex, and 40% said every time, and 60% reported sometimes. Have you used injection drugs in the past 6 months? 20% was yes, and 80% was no. Next slide. Which statement talks about your health right now? And 80% said I'm HIV positive and healthy, and 20% diagnosed with AIDS but pretty healthy at this moment. Next slide. Paying for medical care, 40% say they have some type of health insurance policy. 40% also says they have Medicare, and 20% says other. Next slide. Help in planning or coordinating medical care. 20% specifies that they need it right now, or that they have received it in the past 6 months, or have received it longer than 6 months, and 40% has never received it or it's not applicable at this moment. Next slide. Dentist care, 60% reported that they need it right now. 20% said they have received it in the past 6 months, or they received it longer than 6 months. Both reported there. Next slide. A room, apartment that I can afford. 20% reported that they need one right now. 20% they've received it in the past 6 months, and 60% has not received or it's not applicable at this moment. Next slide. Deposits on room or apartment. 20% say they need it right now. 20% said that they have received it or are currently receiving it, and 60% it's not applicable for me at this moment. Next slide. Help applying for HUD, Section 8. 20% say they need help right now. 20% said that they received it longer than 6 months ago, and 60% never received it or does not need it at this time. Next slide. Help applying for food stamps. 20% received it and has received help in the past 6 months. 20% received it longer than 6 months ago, and 60% never received it or does not need it at this time. Next slide. I need a job. 40% need one right now. 60% never received it or it's not applicable at this time. Next slide. Help writing a will or power of attorney. 40% need help right now. 60% it's not applicable. Next slide. Free personal counseling. 20% has received it in the past 6 months and received it longer than 6 months ago. 60% has never received it or does not need it at this time. Next slide. Support group with trained leader. 20% received it in the past 6 months, and also has received longer than 6 months ago, and 60% has never received it or does not need it at this time. Next slide.
Okay.
Here you go.
Okay, so at this point, this concludes all of our presentation and data sets. If you have additional questions, at this point, instead of sending questions individually to those presenters, please direct your questions to myself, Matthew Eaton, or Patient Smith. Actually send it to all of us, CC all of us, and we will make sure that your questions get answered and sent to the appropriate person. We will also accumulate all questions and share them with everyone so that everyone is clear about all questions that have been asked. Again, I want to thank Matt and Patience, especially for their help in putting together the data sets and collecting people and hounding people about the information. I want to thank Jada Cardona for assisting with technology today and taking our notes and reviewing our questions. And thank you to all of our presenters today for taking time out to present today. This will save us much time on our next community planning group meeting because we won't have to go through this data, but we will have a small section of the agenda where we will have open question and answers related to any data questions that are lingering at that time. So if there are no other final questions, comments, or concerns from anyone, this is the opportunity to say it if you do.
I just wanted to mention when we were talking about the incentives earlier, how people think that that the health should be its own reward. I just wanted to have a quick comment on that. That based on the socioeconomic results that they gave us and the housing problems, you know, how could you expect health to be its own reward if you have those scenarios? Just saying. Thank you.
Thank you. Are there any other final comments?
Hey, Michael, this is Anthony. You said that you're going to make the slides available. You're going to house them where?
Yeah, so we, more than likely they'll be housed on the HIV 411 site because that's the most convenient place for most people to get it. But we'll send out an email specifying exactly where it is.
Okay, sounds good.
If there are no more questions or comments or concerns, again, thank you all. Thank you so much for spending about 35 extra minutes with us. Appreciate it. Have a great one.
Thanks, everybody.